I thank the Muscular Society of Egypt for tolerating me for last 5 or 6 days, and I hope that you people will do for the next few minutes. So, I'm going to speak on something very controversial, and many people do not agree with me. Anyway, let's see what happens. This is where I come from, the south of India, and most of the place is green, tropical, a lot of fish, and swampy. And there are a lot of definitions about arthritis, osteoarthritis, osteopenia, osteomalacia, and arthrosis. The last one is which I'm going to speak about. Myself and Dr. Malay, who is not here, we have been doing some work on vitamin D. And then we compared about 100 patients randomly coming into the hospital with varicose veins, but normally active, compared their vitamin D levels with patients that we were coming with post-thrombotic syndrome or metabolic syndrome, and we found a huge difference. They had a vitamin D deficiency. And all of us know how vitamin D functions. Vitamin D is very important in the absorption of calcium and phosphorus from the intestine. I just researched it and I will come up with the paper. So, in the absence of vitamin D and insufficient calcium going into the muscles and the tissues and the bones, the parathyroid hormones do overact and rapidly demineralize the bones. And the muscles also become a little bit weaker because you don't have sufficient amount of calcium ions to maintain the contraction and the relaxation. This is the basis of what we have been talking about. And of course, whenever you have chronic post-thrombotic syndrome, and ulcers, many of these patients get depressed. They tend to eat a little more and exercise a little, burn out and exercise a little less. So they keep on putting on weight. Once they put on weight, what happens is, especially in the visceral fat, vitamins A, D, E, and K gets entrapped, and you may not have a sufficient amount of these vitamins to regulate the functions of the body. So now what happens in many of these PTS patients? Initially we thought of having a nice protocol and studying them, comparing one leg with the other. But then what we realized after analyzing our hundreds and thousands of patients that we have in India, we are 1 billion plus people, is what we found is very simple. There are so many variables once you have a metabolic syndrome. And diabetes, hypothyroidism, hyperuricemia, arthritis for various collagen vascular disease. And it's very, very difficult to get a sufficiently powered study. So we just left that and we just saw now what it is doing to the patients and what can be done for these patients and what is the picture. We get this kind of ulcers, atypical ulcers all over the place because of either obstruction or reflex from any of the segments in the leg. And with compression, they do heal, but they keep coming back in a different picture. On one of the legs, you will find an atypical ulcer, and on the other leg, an ulcer is not there. And sometimes many of these patients have an altered way of walking. So calcification in the tendons is also a feature because of the increased stretch on these tendons, injury to the tendons, and calcification in the injured tissues. And this is one which of our pictures showing rapid demineralization of the ankle and increased trabecula, which can be seen on an ordinary X-ray. Then initially we thought, okay, we'll compare one leg with the other. Then what happened is we saw either because of the gait or because of the changes in the body, the opposite leg is also affected, and most commonly the medial segment of the knee is affected rather than the lateral segment. And when I went through the literature and our own studies, we showed that there is a perforator close to this particular medial aspect of the bone. Professor Rule has a very nice picture of that in his book. I think all of you should read us, go through that. And this is transmitting the part of the reflex or the obstruction into the bone and causing the stasis within the medulla of the bone, causing again demineralization of the bone. This is another picture. The medial compartment is usually affected. And of course, don't compare the ulcer in the leg with that of the picture. But what happens to the bone is in one of the legs, the X-rays of the right leg and the films on and the picture is of the left leg, atypical ulcers. So whenever you see atypical ulcers or an edema in the leg, please do a Doppler very, very carefully. I was discussing this with Dr. Vasila. See, once we understand that there is a problem, we can treat it. And this is a lymphovenous edema. And this is how many of these patients develop chronic problems in the leg with ulcers and infection. This is how we take a sample. One should always be careful to avoid a fasciotomy in these patients, small compression after admission. And I will slowly wind up a proper footwear, which is not there in many of our parts of the world. Probably it's very common in your country. Sclerotherapy to clear up the reflex to the ulcer. Use of two or layered Pascal's technique. The French team demonstrates this very well, a Pascal's technique, how to do it with only one part of the bandage. And I use sucrose powder to break down the biofilm and lifelong compression. Please, that I believe that the treatment is early physiotherapy, mobilization, and correct the underlying causative causes. Thank you.